Hello and welcome to yet another episode of the Economic Times Consumer Freedom Series. I am Rini Simon Khanna, and together with the country's largest media conglomerate, the Times Group, I'm happy to host a series of conversations for consumer freedom with an intent of expanding consumer choices and protecting the customer in a largely digital era of merchandise. In November 2020, the Times Group, through ET Edge, an Economic Times initiative, curated a thought leadership platform to push the narrative around consumer choice, highlighting the need for progressive regulations to be based on science rather than blanket bans. The multi-stakeholder discussion saw participation from renowned speakers from various walks of life, sharing their thoughts on the subject. The series has garnered a lot of attention and support from our audience, and I would like to thank our audiences for pouring in all their support towards the 5th edition of the Consumer Freedom Conclave, which was held virtually recently on the 20th of September. This webinar reached more than 1,400 million people, garnered 178 favorable media clicks, reached 7.9 lakh delegates, TV, over television, digital, and live, and had 13.2 million impressions. Audiences from various industries such as agriculture, telecommunications, food and beverage, consumer durables, BFSI, automobile manufacturers, tobacco, software firms, and more viewed this edition, which featured conversations on themes such as evidence-based policymaking, empowering community engagement, evidence-based approach to legal reforms, and the Philippines' way of legitimizing alternate, healthier products as a strategy to help smokers reduce or eliminate their health risks, among other important subjects. Today, we have an expert to strengthen our discussion on healthcare policies. I'd like to welcome Dr. Madan Gopal, Senior Health Consultant with Niti Aayog, the apex policy think tank of the government of India, to talk about his experience at the Niti Aayog and focus on some public health concerns. Dr. Madan Gopal is a respected public health professional and has been working on issues related to health systems, reforms, and strengthening in India for around 3 decades. He has worked on a variety of projects across sectors in India and abroad to provide and manage programmatic, technical, and operational areas. And during his career span, Dr. Madan Gopal has held several leadership positions and demanding roles. In his current position, he's contributing to various health sector transformative programs, including the COVID pandemic response. Welcome, Dr. Madan Gopal. Let me start by asking you about your stint with the Niti Aayog. You've been here now for about, 5 years? How has this experience been for you?
Riniji it was very demanding, interesting, as well as very satisfying and contented experience. Because having put in efforts at the field level, I did a lot of sector reforms in Chhattisgarh. So
yes.
Because that was the first state which experimented with a very low donor presence. It was the first state to have a dialogue with the civil societies, chalk out an agenda for development of the state. And based on that, sector reforms started there. And one of the example of that sector reforms, which is being replicated at the national level, is the community volunteer schemes, that is Asha workers. The precursor is Mitarin program there. Looking at the success, and things have happened here as well. The second reform, which has been replicated at the national level, was this state health resource centers, because there was increasing need. Felt that once we are moving towards community participation and community involvement in the form of your volunteers, community health volunteers, they require an institution which has to give technical support for the implementation of this kind of program. Having said this, these institutions were set up in different states, and that has been replicated at the central level. Also, you're having a national health resource center, system resource center is there. Then another thing which I'm just saying here, how I got migrated into Niti Aayog's thing. Then I have to work with the implementation of RSPY. At that time in 2008-9, there was very uh, little take from the government officials regarding the health insurance. When it was offered to me that, "Hey, can you do that in Chhattisgarh?" Then I took up the challenge without an office, without anything. Since I was involved in the health sector reforms, we could at least set up institutional mechanisms there, and the scheme was rolled out there. But after when the scheme was rolled out, when I was interacting with a few of the beneficiaries, they told that this is very much required, and they are looking at this kind of programs. That gave me a lot of motivation, and that has looking at my work, I was asked to migrate to Delhi to assist a central team for this RSBY implementation. And at that time, I came across the few of the persons who were in the Uttar Pradesh when I was supporting the states, 5, 6 states I was supporting in the rollout of RSBY at the program. So some of the people at that time, they were the state functionaries. Then there was some problem. There was one program at Niti, that is sustaining action for transforming human capital. If you are able to transform the human capital, you can have a health sector reforms transformation happening in many of the states. I was called to handle that program. McKinsey and the consortium was there. They have called me to address the issues pertaining to that. After I made entry into that program, and there was a challenge that Ayushman Bharat program was being conceptualized, and they required some expert who was having hands-on experience of rolling out the things. And subsequently, there were advertisements, and I got a lateral entry into Niti Aayog. And one of the first tasks, first stint in the Niti Aayog was to immediate rollout of Ayushman Bharat PMJ program. At that time, it was called as National Health Protection Scheme. Right from the start of the scheme through a health society, transformation of that health society into a national health authority, then rollout of the scheme in the form of health benefit packages that was rolled out, and the criteria for hospital empanelment, the transaction software, and likewise many other things. The other thing which has happened during when we were trying to evolve the transaction software, there was a thought process going on saying that the ministry is having so many softwares. We talk about malaria, you are having malaria portal, you are having TB, the TB portal is there. RCH, HMIS portals are there. So many portals are there. Then we thought that once we are making this PMJ program, so why can't we have a stack where in which all these programs and the web portals can write, and with a common identifier, they can be talking to each other, this program, so that this data set is available for further development of intelligence and some action. This is the way how the things have evolved. So as subsequently what has happened when this stack was developed, this stack resulted in the formation of the National Digital Blueprint, and which subsequently gave inputs to the rollout of the National Digital Health Mission. This National Digital Blueprint is giving an architecture, health architecture, how the digital health would be there. As you have mentioned in your opening remarks, the digital things are happening. But you see how things are happening, and how once you are coming from the field, and if you getting involved into all this kind of thing with the help of others, because it can't be done singly. It has to happen collectively. But if the ideas are seeded, they will germinate and you will see the results. But it will take time, but usually you will see results in this direction. So these things have been very interesting. Another strength is the rollout of the Ayushman Bharat second pillar, that is health and wellness centers. That is comprehensive primary health care, that also started from our organization. And now this is the second pillar. And why these two pillars are important at that time was that in the National Health Policy 2017, we have committed for universal health care. And as we have moved from disease to health, from health to wellness, the vehicles which were there and the approach was the primary healthcare approach. Now we have made the primary health care approach to comprehensive primary health care approach. And the vehicles were your NHM program and the other programs with the vehicles for implementing that. Having said this, but we require more than that NHM vehicle for achieving the comprehensive primary care and achieving the universal health cover. That means universal health cover is nothing but providing accessible, affordable, good quality care with taking care of the financial catastrophe due to any health events. That means financial protection. For comprehensive care, you are having the PHPs, Ayushman Bharat Health and Wellness Centers. And the second, to take care of the financial catastrophe, to reduce the out-of-pocket expenses for at least 40% of the population, for inpatient out-of-pocket expenses taken care by PNJ program. And after COVID, what has happened? So more things have been added. We thought that we should be infusing more on the infrastructure. Then the infrastructure also has been rolled out as a fourth pillar of this Ayushman Bharat, the Ayushman Bharat Health Infrastructure Mission. As I mentioned about the stack is rolled out as a digital mission, which is now called as Ayushman Bharat Digital Health Mission. With these four pillars of things, flagship programs of the government, I think we are very much into the road for this the universal health cover before 2030, because we have been preponing our target for achievement. We have been doing that. So thank you.
It's a fabulous canvas that you have, spread out in front of us. I mean, amazing trajectory that you have yourself personally moved from, a small state into a larger canvas. So while you were doing this journey, Dr. Madan Gopal, I'm very curious to know, what was the biggest challenge that was there ahead of you? Was it infrastructure? Was it mindsets? Was it, the fact that you were moving from a small state to a national level? What was it that you encountered? If you can just name a few challenges, maybe just one or two.
I could not find challenges, but things were there. But the main problem was awareness about how to do things. That is the capacity issues. So whatever limited capacities are there, if you know how to maneuver, if you know how to engineer yourself into that, the good name is there, that is the process re-engineering. If you know how to circumvent the process and re-engineer that process, you will find results. Though infrastructure issues are there, we had the IPHS, Indian Public Health Standards, which talks about what level of institution would be there for a given set of population and what HR would be required.
What about budgetary restraints?
I'm just coming to that.
Yeah.
So that's one thing. Then this was subsequently upgraded to IPHS 2022. But if you look at the IPHS 2012, I'm not talking about the recently released IPHS 2022. At that time, it was told that what would be the number of institutions would be required, what would be the number of HR would be required. And to measure that thing, we were carrying out, we were generating an index so that measure that how far the states have been able to achieve the IPHS 2012 requirements. That requires finances.
Right.
Okay, for achieving the infrastructure requirement as well as the HR requirement, you require finances. And given the fiscal space, the government is having priorities. They have to prioritize the things, because government being the welfare state, they have to see that how they prioritize the kitty which is available. The kitty is not infinite, it's a limited kitty, 20 lakhs plus crores are there. So you have to see that how much you can allocate for the health and how much it goes to education, how much it goes to the agriculture. And that kind of exercise the government usually does. But if you look at the expenses, the way things are happening, every year the expenses are increasing, but population is also increasing. The per capita which we used to spend, previously we have factored 1.5 thousand per capita per year that would be required. But is it adequate? Because that was the thing which has happened during the 11th and 12th Finance Commission time. But as the population is growing, whatever resources we are creating, that have been consumed by that. But still, nevertheless, if you look at because as a signatory of universal health cover, we are saying that for achieving that thing, the public expenditure, that the government expenditure should increase. In the national health policy, what we have factored is that the public expenditure should be 2.5% of GDP. That's the usual things people ask. But
Correct.
how this 2.5% figure came, nobody asked about that.
Yeah.
When this exercise was carrying out, at that time, the GDP on expenditure, the total GDP on health expenditure was around 3.5 lakhs crores. And of this, 70% was coming from the private sector. That is, most of them, what was coming from out-of-pocket expenses. But after a lot of calculation, it was felt that 50% of this should be coming. That was 3.5%. It was 5% at that time. 50% should be coming from the public expenditure. That's why this 2.5%. I usually ask a question that why you are asking only 2.5%, whereas the other countries, they are spending 6%, they are spending 10%, 11%.
Correct.
So we should not be restricting ourselves to that. But major important problem, even if government increases the fund allocation for this health, do we have the capacity to spend? That's the question which we have to ask. Because if you look at the expenditure pattern, the states which are having good capacity, they are spending more. And the vice versa.
Correct.
But the allocation have been happening to the states which are poor performing.
Correct.
But the major constraint which are to me is capacities. If you invest into the building the capacities, then obviously all the other things and the other aspects will improve. That's right. Please.
Right. So, Doctor, when we talk about India, you'll agree that there are a lot of health concerns. And as a medical professional yourself, there must be one main area of focus that you have. I mean, how does that work out, and how do you think the government can improve public health?
I think one of the important things which my teachers, I've been listening, when I was PG student also, I was listening that there has to be a public health cadre. Everybody was talking about public health cadre, but no concrete steps were happening in that direction. So when that was an important thing which I wanted to do and wanted to contribute to the fraternity, because if you look at the way things happen, it's a lot of demotivation of the HR in the health system.
Correct.
Why? Because the doctor who joins as a medical officer, he retires as a medical officer. Whereas the contemporaries who join as medical as a class 2 position at the state level, they usually become directors and the senior most top leaders at the state
so
level.
There aren't enough incentives in the public sector, is what you're saying.
Even if you talk about the auxiliary nurse midwife, that the health worker female, she joins as a A&M and she retires as an A&M. There is no career progression in that direction. So to address all these issues, one of the things which we did, we created an institutional mechanism in the form of development of public health cadre. So that has been agreed now. All the states, they have agreed that they would be building a public health cadre. Why this cadre is important? You look how the states of Tamil Nadu, Maharashtra and Odisha, they have managed the epidemic. They had public health cadre there. And you see, without chaos, despite rising cases, they could manage the pandemic effectively. They have managed because they were having cadre. And the cadre function is to manage pandemics and take care of disease which are of public health.
Correct.
So Odisha also, you see, you have not heard much, but they have managed the things beautifully. In Tamil Nadu also, despite the high number of cases, all the other states were having a mixture of RT-PCR, that is rapid test, and the RT-PCR. But they were only doing, that was the only state which was doing maximum number of RT-PCR. That is more than 95% tests were RT-PCR. So because they have understood the importance of that, I'm just highlighting the fact that if a cadre is there, public health cadre is there, public health management. That's what one thing. And the work is in progress, and some of the states they are into the implementation of this. So that was the one biggest reforms which we could push from the Niti side. That's one thing. Second thing is in the medical colleges also, because we have been talking about the reforms in medical education. You see how the erstwhile National Medical Commission got transformed into the Medical Council of India got transformed into the National Medical Commission. And see, in the last 10 years, exactly how many number of medical seats have increased from 30,000 or it is now nearing 100,000.
And yet is not enough.
No, it's not enough, but things are working. Now you see the vision that every district should be having a medical college. now we are moving in the direction. Only about 100 districts are left where there is no private or government medical college. Second thing, second important challenge which we are facing is to handle the communicable disease. There are certain areas we still have the communicable disease, and now the upcoming NCDs and the trauma and the accidents. So we are very much conscious about all these things, and we are moving in that direction, and see that in the coming days you will be hearing more about what new initiatives are happening to address these issues.
Which brings me to the next question about initiatives as far as the government is concerned. You mentioned some of the measures that are being taken. I mean, the public sector having a cadre which is being specially created, and some of the other incentives that you have put in place. What are some of the special initiatives that are planned for the future for public health in India? And also, if you could elaborate on why harm reduction is a critical element of public health.
As I mentioned, that one of the important reforms which is happening is public health cadre. The second things are that there are many diseases like leprosy, filaria, leprosy, filaria, mumps, measles, measles, rubella. They are at the verge of elimination. So can't we put all our efforts and see that these diseases are eliminated? That's one of the initiatives which we are trying to target. How we can do that. Second thing is one of the important things about the blood-related diseases, sickle cell anemia. Can't we screen all of the population and see that who are having sickle cell disease so that they can be put on treatment and their life can be modified? So other important aspects which is there is the screening of the population for cancers and your NCDs, non-communicable disease, and see that how we can provide continuum of care to these people. The moment they are screened for diabetes and hypertension, a continuum of care, that means every 3 months follow-up should be there, medicines have to be provided, and that kind of things are evolving. And as I mentioned about the universal health care, so we have to expand the gamut of the universal health care. You look at how the population are insured. Health services are free for the country. If you and me can also visit any government institution and avail services there. But even when you are availing services as per the reports, that is National Health Accounts and the NSSO data, you see that the person incurs some expenditure. How to reduce that expenditure? You are having for the 40% population for taking care of the inpatients, you are having the PMJ program. Now, efforts are being made seeing that how the scope of this PMJ program is increased. You are having other programs, the ESIS program, that is the Employee State Insurance Scheme, which covers around 13.2 crore population. With the enforcement of the Social Security Code 2020, the scope of this scheme would be to cover around 18 plus crore population. That means with all these things, at least 80 crore of our population would be having some kind of financial protection in form of either assurance, in form of this, because state level schemes are also there. The another thing which is happening is how to improve the quality of care at the government institutions as well as at the medical colleges. So very much work is happening in that direction, and we are trying to see that how the existing programs which are there, how repurpose or the re-engineering can happen so that the effectiveness of all the initiatives which are happening that increases. TB elimination is already there at the radar. By instead of 2030, we have preponed the date for elimination by 2025. And all the people, they are making an effort in that direction. You will be seeing more such kind of initiatives in the coming.
Would you also like to elaborate a bit on harm reduction?
Okay. Sorry for, because harm reduction, as we have been discussing, the situation of tobacco consumption. India is facing problem of tobacco consumption. Tobacco smoking is more or less now is limited to only certain elite population, but tobacco consumption is very high. The ill effects of tobacco consumption needs to be reduced. There would be many school of thoughts, but from a purely public health point of view, you have to see that the demographic dividend which all boast and claim about, are we able to deliver, are we able to cater health services for these people? If you look at the study, the economic situation of the people, how many people are there in the top quintile in the income bracket? Even if some substitutions are being provided for this tobacco and that kind of products, how many people can afford that? If you look at just a small arithmetic, if you look at the COVID vaccination, for giving vaccination, you can calculate the whole of the country has been covered and you have expended around 50,000 crores, more than 50,000 crores. And the budget of the health NHM is roughly around 50,000 crores for the whole year, running many programs. When you are talking about public health programs, then you have to see what kind of kit is available and how you prioritize these things. Primary health, as per the national health policy, primary health care, prevention, promotion, and that kind of activities take precedence. 60% of the budget goes for that. So that's why there is more focus on preventive aspects, how you promote the reduction in use. The answer which you are seeking, it will be very difficult for me to answer. But the major focus is there on prevention of this kind of thing, and you might see a lot of activities spiraling around that.
Yeah, I agree with you. I mean, in principle, but I'm wondering whether, we are doing enough as far as harm reduction is concerned. I mean, cigarette smoking still remains the single most important avoidable cause of death worldwide. I mean, and India records approximately 1.3 million cancer deaths annually. So how are we going to be able to balance this out? I mean, while we're talking about harm reduction and we're looking at only preventing some sort of reduction in this by anticipating that, all right, there is a certain population that will be consuming tobacco or at least moving towards smoking tobacco. How can it reduce these deaths if we don't tackle it at the root of it? Preventing cigarette smoking.
The problem is, if you look at the recent survey, 25 crore people, they consume tobacco. It's not a small number. Okay. And if you look at the age at which the tobacco consumption is initiated, it's very less. That means 9-10 years the people are initiated to tobacco.
Correct.
And this tobacco, unless some stringent measures are taken, this will lead to further addiction, because this is a lower form of addiction. You start with tea or coffee, then you require more that kind of fix.
Correct.
Then you take the tobacco, from tobacco you take the other, and then that's why things happen. You have to see that how you take stringent action. Managing even 25 crores means 4 times the size of Britain, 3 times the size of Germany, and equal to USA. You are dealing with that population. And it cannot be that you can provide an alternative for them. Government to provide an alternative, the nicotine patch and other things is very useful. If you take the example of smaller countries, they can have that kind of bandwidth to cater all these things. But here we require, for managing 25 crore people who are consuming this, you require some other different kind of yardstick, not the similar thing which has happened in the smaller country.
So when you say that we need a different kind of yardstick, do you think that our harm reduction policies need to rely on research-based data, or like you mentioned, I mean, should we be actually taking the example from other countries and their policy decisions?
Riniji, when you look the vaping thing which was banned,
yes.
So there was an expert committee constituted under ICMR. This expert committee, looking at the data and the other evidences, they have made a recommendation. It's not based on the arbitrary decision that means you will be banning. There is a ICMR is there which collects data, which do studies, and based on the recommendation of the expert committee, such decisions are taken. Correct. If a evidence is available that substitutes are good, so this expert committee can take a call. They can recommend to the government, and the government will then take a call on that. It's not that different, because we also follow the same kind of evidence-based policy approach as followed in the other countries. But since the size and the magnitude is smaller there, the size and the magnitude higher, we have to weigh pros and cons of any decision which happens and any policy decision which should be taken.
I don't know, Dr. Madan Gopal, whether we are actually just, using the status of having a larger population, and hence the scale of this exercise is going to be, almost near to impossible, as an excuse. Because, when it came to vaccine dissemination, I'm not saying that you are, but I'm just saying that, I'm putting it out there because, the common man thinks that, okay, the vaccine was also something that we thought, oh, never, will India be able to achieve this target? And yet we were able to roll out a very successful vaccine policy, and we were able to cover the maximum number of people. So why is it that when it comes to...
No, it's not that. There's a common perception that when we were talking, it's a government which always believed that it can be rolled out.
Correct.
All the noise was being made by the different stakeholders saying that India will take 10 years for this. I'm having quotes and other things of that persons. So they told that it will take 10 years. But even during my TV interviews, I have mentioned that it's all demand driven and supply driven. The moment supplies improves, you will find that I won't be surprised. That was my words. I won't be surprised if we could have more than 2.5 lakh vaccination centers. And that has happened.
Correct.
Because that kind of capacities are there. It's not that we are...
So shouldn't that, that result, that successful result, spur you actually to, say that, all right, let's roll out a very aggressive, policy to be able to stem this in the nascent stage itself before it becomes, much larger than possible to handle.
And that's why the policy level initiatives are to be planned. That means how to see that this tobacco and that kind of products are not available near the vicinity of the schools and other places.
Correct.
So people are making efforts in that direction. How to see that the person is not initiated into tobacco consumption in his early part of the life.
Correct.
Then for the people who are already on tobacco, we can find an alternative for them. That kind of thought process we can always have. Yeah. But see that as happened in the other countries, in Australia and other down south, you see that the younger people, they are not allowed to get into this tobacco business. So tobacco business means they can't buy tobacco.
Consume or buy it in any form, right? Sir, when we were researching on tobacco consumption in India, we really couldn't find any data on NDAP or any valid information about how many smokers and tobacco consumers actually want to quit, and how many are struggling to quit, and what are the various ways in which one can either quit or at least reduce the harm caused by these tobacco products. Do you think that there should be a survey or a report on this topic, and this could actually help the government in achieving its goal of tobacco users being reduced?
I think there are different differentials of this tobacco use, consumption, the effects, harm effect, the willingness to cease tobacco consumption or quit tobacco consumption. That kind of studies should come out, and it should not be biased. Means some independent person, they can take out the study and they can present the result to the expert committee, whichever expert committee is handling this at ICMR. They can present it and see how the things move from that direction. A dialogue can be created around this, and the moment dialogue starts, then you can always have an option that yes, some more ways of looking at the things can happen, and accordingly policy level initiatives can be tweaked, or some that kind of efforts can always happen.
Which is why the Times Group is also engaging in conversations like this to be able to increase the dialogue and discussion that happens around the topic. Sir, the Philippines, which will soon have a law to regulate less harmful alternatives, is actually leading the Southeast Asian countries to look at adopting tobacco harm reduction as state policy and legalize smoke-free products. What are your thoughts about the Philippines policy decision? And do you think that the government will enact the vape law?
A lot of work is required to be done. We have been approached by many of the people saying that non-smoke tobacco products, the hot vaporized tobacco products.
Yes.
We told that we have directed that they should be trying to generate more evidence surrounding that, so that they can convince the the expert group here. So for that, basically what is required is to do studies.
Hmm.
So for the studies, the mechanism is there, regulatory mechanism is there. They have to apply, they have to demonstrate their products. Three, four people, they have already approached that. We have guided them how to carry out these studies. So we can always guide people saying that if they want to generate evidence, take the clearances and do the study, come up with the results, and try to influence whether that would be useful for policy or not. That's a different set of questions. But at least it will start the dialogue process forward. So that very much required. This evidence generation is very much required.
So I'd like to come back to this, very important question about what is the kind of data or research that would help identify that for us. But I want to also talk about, drug overdose, which is a huge public health concern among injecting drug users who are using opioids. Overdose and associated deaths call for urgent action. Do you think we are doing enough when it comes to opioids and overdose?
This problem has been handled by NACO very effectively because the opioid substitution therapy, because there they could at least crack that issue, because what has happened is the injectable drug users, they are very potent way of transmitting HIV. So instead of injecting drug users, a substitution, oral substitution was being offered as a harm reduction thing, and that has worked there because you are blocking the chain of transmission of the infection through needle. That was effective. But what happened? This is very challenging thing because the overdose and other things. What happens is that as the refinement things happen, because it's a gray market, there are no standards in that.
Correct.
The refinement happens sometimes the higher concentration things is available, sometimes a lower concentration this vial is available for injecting.
Yeah.
So as a result, what happened if somebody injects some drug? So as an addictive effect means the drugs are having an additive effect. You are taking a small 0.1 gram, then after a week or 10 days, you will require a higher
dosage,
higher dose for this. But our body is having a threshold. As a result, unless and until all the injectable drug users, they are brought for oral substitution. That's the therapy which is available. Oral substitution followed by the other methods like de-addiction, other things. That has to be taken seriously. We are doing it, but main problem is finding the people and bringing them to the system. And another thing is, we are still.
And are there enough substitutes available for this?
Yes, the opiate substitution is quite effective, but the main problem is decriminalizing the drug users. That's a major challenge because somewhere you go to some of the streets in Delhi, you will find the drug users standing there. The law enforcement, they doesn't touch them because the moment they pick them, they have to provide them an alternative for them. Right. And the two ministries which are doing, one is excessively focusing on de-addiction. That is not work. You have to provide oral substitution so that they can go back to their work effectively and provided with the counseling and the de-addiction. Both the things have to go simultaneously.
And
a lot of work is required to be done. It's not that still work is in progress. A lot more is required to be done. It's not it's very complex issue. It's not that simple. Enough is done. Whatever you do, more and more younger populations are getting involved into this drug habits. You see that how to break the change, that they are not induced into this. The best way is to stop exposure to any of this kind of thing, including your tobacco consumption right at the early age, as in 9-10 years. It starts from there. And as the addictive effect increases, they want to have a bigger and more potent or a stronger kind of this kind of drugs. As a result, unless you stop there, so this will have a snowball effect and you will find more and more such kind of people.
Right. Dr. Madan Gopal, I want to come back to what is the kind of data and research that would help the government identify the alternatives or the solutions to tackle the tobacco-related deaths that you think should be provided?
we should start. The data is very tricky issue, because the thing which is collected, the thing which is watched, the thing which is asked, that gets monitored and that gets gone. So that's why the data, whatever data you are asking, if it is watched, if it is monitored, the governance will happen, things will happen. But if you're not asking data, then things will not happen. So it will start right from the practices. Even if you look at the data which we are collecting at the school, during the school health survey, we should have a column on collecting information whether the child is consuming tobacco or not. Whether it is, but it is very sensitive thing, but we can think of including that column asking about any addiction right from the school health survey days. That's one thing. Second thing, when you are talking about when you are taking history from the women, you should have a questionnaire about question about the tobacco consumption. So that is during the last discussion, one of the discussions, it was highlighted.
So as part of the ANMs and the primary health,
as a part of the ANC care, the question is to be asked, so that the data collection starts and the various parameters which are collected along with that can be analyzed and put to use. Apart from that, many NGOs and others, they carry out periodic surveys. They can, when they are collecting the demographic profiles and the socioeconomic profile, they can include a column on tobacco consumption and other drug abuse and other things. That needs to be part of that. There are many data sources which are coming, but these are all haphazard. Unless you collect information, to the information and the other association with that, it is,
and probably verify that information as well. I mean, it's not just enough to get the data, but it has to be verifiable data.
It has to be verifiable data, because the data quality over the years has improved a lot. Whatever is collected, because people will not put in data which is of no use. The moment you start asking data, it would be verifiable. And why I'm saying this, because during the data which is collected by the system, I can talk about the health public system, because private system, they don't share data with anybody.
Correct.
Okay, except the tuberculosis and few of the disease during the COVID time they have shared. Otherwise, they don't share data. But in the public system, you look at the data which is collected at HMS, Health Information System, and the NFHS survey, which happens every 3 years now. So there's little discord between this data. What is observed in the system is now in the surveys also you are having the similar kind of data. That is coming. That means data quality is improved. But the important bottom line is, are we collecting that information or not? We start collecting that information, then you can correlate the consumption pattern with the disease. You can correlate the consumption pattern with the behavior and the other progression of other elements as well. So important thing is, whenever you are doing the school health survey, try to see whether they are 9th standard, 10th standard, just have a questionnaire saying that, just have a row in the questionnaire saying that whether the person is consuming tobacco or any other drugs and other things. But whereas in the ANC checkup also, they can take the history of this. When it starts from that, you will have information at the national level. And the cancer registries and other places, they do have the information, but it's all retrospective post-mortem analysis. That means the event has happened. But if the consumption pattern starts increasing right from the school days, then you can see that what kind of measures can be taken. Can they reduce the excess there? Can they reduce the availability of that substances there? So usually it is like that only. Right. So we have to move in that direction, but right now it's not there.
Right. So, Dr. Madan Gopal, you've been at this for a very long time. The 5 years that you've had at Niti Aayog has given you a ringside view of what lies ahead, what lies behind us. And I would like to ask you at this moment now, you've got the benefit of being able to see behind as well as forward. What are the future healthcare policies that you would like to flag? Are there specific policies that you would like to talk about? If you can just kind of give us a broad overview of what lies ahead for us.
One of the things which I feel that needs to be talked about in the coming days as well. One is two things. One is the quality of care, because we have been talking about access. Access is there. You have made the things affordable. But what about quality? If you talk about the quality of care, the NABH accreditation started way back in 2007, but still long way to go. NABH hospital, it's a very stringent, patient-centric, patient safety-centric quality standards. But how many NABH hospitals are there? That's a long way to go. But still, there are many parameters. Now you are having Laksha certification, so that is also moving there. But similar kind of thing can happen in the private sector. To one thing, but everybody is looking at the government for creating standards and quality. But if you look at the European countries and the other well-developed countries, it's a chamber, it's a professional bodies which deliver such standards. They create standards for themselves, they create protocols from themselves. So I have been pushing this, and we like to see that these professional bodies, they come forward and make standards for themselves. We, from the government side, we are having NABH standards, QCI would be having, but professional bodies coming forward and creating standards for them. Foxy Federation of Obstetrics and Gynecologists, they are having the standards. They are having standards in the form of Vanita. They have standards for normal delivery, hysterectomy, and the Caesar section. They have come up with the protocols, and any of their members, if they are doing C-section, they have to share that information. That kind of mechanism is now evolving, and in the coming days, you will be seeing this. Second thing is the regulation. We have been talking about the regulating the medical practice or medical institutions. So for that, we are having a Clinical Establishment Act, which was enacted in 2010-11. In one decade, many few states, they have adopted it. That's standards for the clinical establishments and the practice. But still a long way to go into that, how to regulate that. Other thing is price regulation in the private sector. If the professional body, they come up with the algorithms and the protocols, obviously people can work towards having a price, and they can at least deduce a price, and price regulation can happen. And you see how the price regulation has happened. During the RSVY days, you have seen that it has created at least a minimum, what could be the minimum level of package for a particular surgery. And PMJ program is re-established that fact that for a particular process, this kind of number is there. You can be 20% above, you can be 10% below, that's up to you. But the prices in the private and the other big institutions is quite opaque. At least in the coming days, as things get evolved, you will be seeing more or less a uniform and standardized pricing in the big hospital, the small hospital, and the very small hospitals. That kind of thing can happen. And lastly, a lot of changes are going to happen in the human resources. We are having the National Medical Commission, which is trying to focus on the quality of medical education. You are having the Nursing Medical Council focusing on nursing education. And this is one of the important neglected areas. So a lot of impetus is there on the nursing education, and the allied professionals are there. So compounded by that, you'll be seeing a lot of states having a public health cadre, so that whenever any pandemic happens, that will happen. When we are talking about this, as we are talking about pandemic, now the focus is now shifting from pandemics to One Health. That means as our interaction with the animal world and the agriculture world is increasing, and the international travel is happening, that means the disease which are primarily from the animal, they can jump into the human beings, and the plants, you can get this. So that would be the focus in the coming years, and that would be a kind of national security also, if you can talk. That means pandemics and others, unless you are very much aware about this pandemics and One Health, so it would be. These are 3-4 areas, I think, in the coming years you will be seeing a lot. Apart from that, the routine sustaining activities like providing RCH care, the NCDC care, and that will be there. That is the evergreen thing, and as the population is growing, and this. One important thing which we have to focus in the coming years is the population. Whatever resources which we are creating, even for 10 years down the line, are they sufficient unless we at least reduce the inflow of the population? So otherwise, resources would be all taken up. Correct. You see, We are having around 25 lakh beds in the country. Are they adequate? You create more. We are having how many? If you take 10% as cancer beds, are these adequate? Because the moment you try to create this, each bed is costing around 20-25 lakh rupees. That means including the not the furniture, the staff and other things. It's only 25 lakhs. So how many more resources we can create if the population is not taken care? So that's an area I think the call has to be taken at the very high level. So, but that's an area I think we should see how we work around that.
Thank you so much, Dr. Madan Gopal, for being so candid and sharing all those concerns that you are, positioned in such a way to be able to help the nation with, and give us that information and be forthright with your responses. Thank you so much. It was really a very insightful session, and I'm sure that our audiences would have enjoyed it as much as I did interacting with you and conversing with you. Thank you so much for watching, friends, and do join us again as we continue to bring you interesting conversations with leading figures as far as consumer freedoms are concerned. Thank you and goodbye.